Heads up healthcare professionals, it's time to book your place. MIMS Learning Live South is returning to London on Friday 13th of June 2025, and this year we're heading to a brand new venue, the ILEC Conference Centre. Brought to you by MIMS Learning, this is the event you won't want to miss. It's your chance to boost your clinical know-how, connect with peers from across the UK, and gain fresh insights that can make a real difference in your patients' lives. Spots will go fast, so don't wait. Head to mimslearninglive.com/London and grab your ticket today.
Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Dawn Liz Powell, Medical Editor at MIMS Learning. Today, I'm delighted to welcome back our Mental Health Clinical Advisor, Professor Carolyn Chew-Graham, to the podcast. Previously, Carolyn spoke about what GPs and other primary healthcare professionals can do to support people with severe mental illness. For this episode, she will be looking at supporting people with learning disabilities. Carolyn, can you just remind our listeners of your day-to-day role and what your interest is in mental health?
So I'm a general practitioner and I'm also Professor of General Practice Research at Keele University, and much of my work is around mental health interventions in primary care, and that spreads across from common mental health problems, people with severe mental illness, and also anxiety and depression, which are comorbid with other conditions.
Thank you for that. Okay, so what do we mean by learning disability? Am I right in thinking that something like dyslexia, although it can cause difficulty with learning, is not considered a learning disability?
Yeah, so it's worth thinking about what the Diagnostic and Statistical Manual of Mental Disorders say is a learning disability. And it's an intellectual disability that begins in childhood and is characterised by intellectual difficulties, as well as difficulties in conceptual, social and practical areas of living. So people with a learning disability tend to take longer to learn and may need support to develop new skills, understand information and interact with other people. But things like dyslexia, dyspraxia, although can cause problems in learning, are not necessarily considered to be learning disabilities, although people with those problems like dyspraxia and dyslexia may need additional support with educational activities.
We have had a lot of discussion in recent years about neurodiversity, like particularly autism. And then I think there's within the autistic community, there's an increasing view that their condition is an identity to be recognised, accepted and accommodated rather than a disorder. We should perhaps just clarify that while there are some autistic individuals who have a learning disability, autism itself is not a learning disability.
Yeah, that's correct. So as you've said, that people with autism or autistic people, as I think that group prefer to be known as, they may have comorbid or coexistent learning disabilities, and they may also have comorbid or coexistent anxiety and depression. So they're much more at risk of those comorbid conditions.
Okay, so we've got someone in the practice. We know that they do have a learning disability, whether or not they have autism or a learning difficulty, but they have a learning disability. People with learning disabilities tend to have poorer physical health than those without a learning disability. What are the reasons for this?
Okay, so there's a number of reasons, and I think it's quite useful to think about the parallels for people with severe mental illness. So they have an increased risk of comorbid physical health problems, long-term conditions, and that leads to a reduced life expectancy. And it's the same in people with learning disabilities. The physical conditions can contribute to a reduced life expectancy. And those comorbid physical conditions include respiratory conditions, so asthma, which may be poorly controlled because of difficulties using inhalers, COPD, which is related to smoking. But they may also have multiple conditions. They may have diabetes and heart disease and arthritis, which makes the conditions complex to manage and also increases the risk of polypharmacy and then obviously the risk of side effects from those prescribed medications.
So you're saying that people with learning disabilities can have a lower life expectancy than those without. Can you expand on that?
The other thing is to say that some of these deaths are avoidable or preventable. It's not inevitable. And so there's a number of reasons why the life expectancy is lower in people with learning disabilities. Possibly they don't receive the same quality of care that the general population receive. There's lack of coordination and integration of care. There's a greater likelihood of adverse events. So I mentioned just about polypharmacy. People may not complain of side effects, not notice side effects of drugs. And people with learning disabilities may not access care. So they may not access routine care for if they've got a long-term condition like diabetes. They may not access care for an acute problem in a timely manner, or they may not be facilitated. They may not be brought to the practice to access care. They also may not come for, say, breast examination or cervical screening. They may not come for vaccination. They may not be offered support for being overweight or for smoking cessation. And so when I say people don't attend, I'm not at all blaming the person with the learning disabilities. It's often that they may not be brought by carers, or that the health service is not really accessible to these people. We don't make the changes and arrangements that we ought to make.
Okay, so how could we make care more accessible for someone with a learning disability?
So there's quite a lot of barriers if you think about, say, trying to access primary care. So first of all, they may not be able to use a telephone. They may not be able to use the online query system that we're all encouraging patients to use. They may have poor literacy skills, so they can't read the instructions. People with learning disabilities may come to the reception desk, but then can't make their needs understood. And CQC does say that staff should all have adequate training in how to support people with learning disabilities. Somebody with a learning disability may not have a carer. They may not have a representative or an advocate who can bring them to the appointment. Somebody who lives in supported accommodation, there's often a lack of staff. So a person may have made an appointment or have been offered an appointment for a review, but they don't turn up because there's nobody to take them. And I think the information that we give to people with learning disabilities, so maybe a cervical screening invitation or an invitation to a long-term condition review, may not be appropriate. And we should be thinking about other ways of giving information. So maybe using infographics, or there are booklets that are designed for people with learning disabilities that explain what a cervical screening is or explain what vaccination is. So there's lots of adjustments that practices could make to make them more accessible to people with learning disabilities.
Just to clarify that, I think you're talking about the CQC. That's a Care Quality Commission.
Yeah.
Okay. I mean, I suppose some of those adaptations you could use for someone whose English isn't their first language and perhaps doesn't speak English very well, because that could perhaps be beneficial to them as well, could it? Or
the adaptations that are needed for one group of people are often the same that are needed for others. So people who don't have English as a first language, people who've got learning disabilities, people with severe mental illness, people who've got health anxiety. So I think we should, as GPs, just make sure that our practices don't expect that one size fits all, that everybody can understand the information we send out, that everybody can use the online booking system. That's not the case, and we should be making adjustments. And in fact, the Care Quality Commission is very clear that general practices must make reasonable adjustments, and it's under equality legislation to provide equitable care for people with learning disabilities.
I think there's something called the Learning Disabilities Health Check Scheme. Can you say what that is? And is that something that can be used to support good physical health in a person with a learning disability?
Absolutely. So at the moment, there's a Learning Disabilities Health Check Scheme. It's a local enhanced service, which means that practices can choose to deliver it, but most practices will choose that because it obviously forms part of their income. I suppose my concern with all these local enhanced services is that sometimes they are instituted, but then the funding disappears and practices may not then have the resource to continue to do it. But at the moment, it's in place. The scheme provides funding for practices to offer a health check for people with learning disabilities, anybody over the age of 14. So practices have a learning disabilities register and invite people at least annually to have a health check. And it's the idea behind the health check is to identify any undetected health conditions, but also to monitor any long-term conditions that they have, think about vaccination status and other screening, but also think, and perhaps most importantly, is to establish a relationship with the practice, to establish trust, perhaps to provide continuity of care. So particularly in bigger practices, it may be that a person with learning disabilities, or any patient really, may not always see the same healthcare professional each time they attend. But if every year they see a healthcare assistant or a nurse practitioner who delivers the health check, they build up a relationship and trust in that person.
It depends what the person's with a learning disability situation is. But say, for example, they're a little bit younger, so they perhaps wouldn't be eligible anyway for the sort of over 40 health check. If they're perhaps living with a parent and that parent's a bit older, in terms of resources, there's such a thing at the moment in primary care, like you think, well, you're getting the parent in for sort of a diabetes check or some sort of health check. You think, well, that would be quite a good time to combine the two, that you're sort of getting the parent in for something and then you get the child in for their learning disability health check. So would it be something like that?
So the learning disability health check is for over the age of 14. It's important to offer opportunistic care. I think it's also important to say this time is for you. So for the parent, if they're coming in for the diabetes check and you know that they are a carer for somebody with learning disabilities, I think that's an opportunity to say, and how are you doing? Because we know that carers have an increased risk of anxiety and depression, and they may not disclose that, they may not want to admit it, there's a lot of stigma. But so coming in themselves for an appointment, particularly if they're on the carers register, gives that opportunity. And I think the health check for the person with learning disabilities should be an appointment for them, and it's made clear that it's for them, it's about them, and it's to monitor them, to check their medication, to do physical health check, to ask about alcohol and drugs and smoking. And again, there's a parallel with severe mental illness. It's not just about ticking the boxes and saying we've done this, it's actually acting on the results. So if the person says they're constipated, get them to see the GP or the pharmacist. If they're on lots of medications, they need a medication review by a GP or pharmacist. If they've got problems that they're smoking, what about the smoking cessation services available either within the practice or in the locality? And so really focusing on that person. And whilst occasionally we can do these things opportunistically, in a 10-minute consultation, it's really difficult. We have half an hour appointments for learning disabilities review with a healthcare assistant in our practice.
Yeah, I suppose I was just thinking you'd have two separate checks, but just coming them back at two separate times, getting them to come at the same time.
Yeah, so trying to coordinate it, that would be great, wouldn't it, if we could do that? Yes.
Yeah.
Yeah, and I think some practices are good at actually knowing who lives where, and so we'll sometimes bring a couple in who we know that they both do their diabetes check, so perhaps they could come in one after the other. It saves on transport, it perhaps increases the chance that both of them will be seen.
There's pluses and minuses to that type of approach, really, isn't there? Before, we were sort of making a reference to mental health, and so as well as tending to have poorer physical health, people with learning disabilities tend to have poorer mental health. Can you sort of expand on that?
Yeah, absolutely. So they may have common mental health problems like anxiety and depression, and they're quite difficult to actually diagnose. So somebody with learning disabilities who's depressed might be very quiet, might be withdrawn. Sometimes the carer might think, oh gosh, that's good, that the behaviour's a lot better, I can manage them. And actually they're depressed and they need some help for that. Sometimes people who've got learning disabilities and are anxious or depressed can be quite irritable, quite angry. And so again, it can present as a behaviour rather than somebody saying, I feel depressed or I feel anxious. So we need to be aware as GPs of the increased risk of those common mental health problems. But also people with learning disabilities are also at a much greater risk of severe mental illness, such as a comorbid psychosis. And then obviously dementia in people with Down syndrome. And as we've said already, there's also a risk of comorbid neurodiversity.
You mentioned about dementia and people with Down syndrome. Does it present differently? I mean, because somebody with Down syndrome, what would be like, oh, this is dementia rather than just their symptoms or just typical behaviour?
Yeah, that's really tricky. And because people with dementia who haven't got learning disabilities can present in all manner of ways, it isn't just about memory loss. And often in people with learning disabilities, it's a behaviour, the change in behaviour that indicates there's a problem. And that problem underlying may be depression or anxiety or a psychosis or an early dementia. And this is where we really need the support of either learning disabilities consultants or old age psychiatrists.
There's so much stigma still about people with learning disability, just the names that you would get called in the playground.
Mm.
How might stigma and other psychosocial factors lead a person with a learning disability develop a mental health problem?
Yes, I mean, there's lots of factors that impact on the development of anxiety and depression. So if we think about common mental health problems, and some of that is genetic. So people with learning disabilities who have got a strong family history of common mental health problems, particularly depression, may have an increased risk. But then, as you say, stigma and sort of name calling, gaslighting are important. Social isolation and loneliness, we know those contribute to depression in the general population. And we know that people with learning disabilities are much more likely to be socially isolated and lonely. So that might contribute to depression. And then, of course, that socioeconomic deprivation and unemployment can lead to anxiety and depression.
I suppose it's just as the same sort of factors that could cause somebody without a learning disability to have depression or anxiety are going to be exactly the same factors.
Yeah. But I guess for the GP or for the clinician, it's perhaps more difficult to tease out what's going on. So somebody without a learning disability who you think is depressed or they present thinking they're depressed, you can ask questions about unemployment or employment, job, work stress, what's happening at home. You may not be able to, depending on the capacity of the person with learning disabilities, you may not be able to have that consultation. You may not be able to get to their feelings. And as I've said already, it's often the behaviour that is the clue that something else is going on. And it may not be the person with learning disabilities who identifies that this is a problem. It may be carers or support workers who say their behaviours change, they're erratic, they're not sleeping, they're running out of the house, they're not eating. So it's taking a slightly different history, and it takes a lot longer, I think, in trying to make that diagnosis. And again, it may be something that the GP doesn't feel comfortable to do. But you should have a high index of suspicion and then have access to learning disability psychiatrists who can pinpoint, exactly what the diagnosis is. And more importantly, I think, advise about treatment. Because the other thing that we've not mentioned is that people with learning disabilities tend to have higher rates of psychotropic medication prescribing than people in the general population. And there's the thing about the chemical cosh, that behaviour that isn't tolerated by other people is often treated by the use of atypical antipsychotics, which have their own problems, including metabolic side effects, which increase the risk of physical health problems.
Basically, people with learning disabilities are on this psychotropic medication, and sometimes that's kind of quite complex because sometimes they shouldn't be.
There's two things. One is that they may be prescribed psychotropic medication, perhaps as a young person, and that has never changed. And so you occasionally find people on depot antipsychotics and as a GP and think, I'm not quite sure why this person's on this. And you have to go back sort of 20 years. They're not under psychiatry anymore. And then as a GP, you have to think, so why are they on this? Can we alter it? Can I get a learning disability psychiatrist to review them? But I think when people present with changes in behaviour, they often are prescribed sedatives, anxiolytics, and antipsychotics to manage that behaviour. And that may be appropriate. It may be the only thing that can manage the behaviour. And I think when people are in supported accommodation or residential care, I think that. But then the antipsychotic medication also then causes physical health problems. So cardiometabolic changes, obesity, diabetes, and that adds to their physical health risk.
So you're talking now about being in residential care. Some people with learning disabilities live in residential care. Some people will live with their parents as adults, and some people will have at least some level of independence. Because you said before about ensuring the information is accessible, but how do you ensure that you're respecting their autonomy and ensuring that this person that you are seeing, that this person, they might not have the same level of understanding as somebody else, but they still understand and they want to make their own decisions, and respecting the fact that they want to make decisions about their health. And even if you might not necessarily agree with those decisions, it's their right to make that decision about their health. Say you've got somebody who just is a made-up scenario. They sort of live independently, or they do sort of have some independence, and they're sort of seeing you by themselves, and you've kind of diagnosed them as quite something serious, and they've got to make a major decision. What happens if you think this person has to make a major decision, they think this person doesn't have capacity to make this decision?
I think you've raised an important point, because somebody might have capacity about one thing, but not about something else. So in every decision that we have with patients, and we don't always make it explicit. So I might say to somebody, we're going to organise a blood test. And I make the assumption that people know what that is, that they are going to retain that information. They can weigh up that information and make a decision. They could communicate that back to me, that they understand they're having a blood test. So that would be assessing capacity. And I don't do that with the general population. I assume that people know what a blood test is. But with somebody with a learning disability, I'd have to start right from the beginning. Do you understand what a blood test is? How it will be done? This nurse will come and do it with you. I might give them an infographic explaining it. And then I would say, well, we've just talked about having a blood test. Can you just tell me what that means? So I'm asking them to tell me that they've understood what I've said to them. They've retained that information, and that I feel that they understand the decision they're making about having a blood test. So for a blood test, that's really simple. But actually, I might get to the stage with that person, actually, they've got no idea and they don't have capacity to make that decision. And for something that's more serious, so postmenopausal bleeding, for example, or the bowel screening that comes through the post, so they've done that with the support of their family member. But then it was positive and they were called in for a colonoscopy. And so that's a very different decision about whether they understand what they're having and whether they consent to that. And so if you feel that a person doesn't have capacity to make a decision about that particular thing, if it's an urgent situation, if it's an emergency, then, obviously we have to make the decision in the person's best interest. If it's a non-emergency, we can involve the carer or the support worker. And if we feel that we've got shared decision-making there, then we can go ahead. But sometimes, actually, there isn't a carer or support worker, or they don't feel able to assess this. And so you have to then get the law involved and make a decision about the person's best interest that is covered within the legal framework.
Just because I've just been thinking about it, you see some really horrific news stories in the press, and of course these are often very rare examples of abuse that's gone on at care. Somebody's been caring for somebody and they simply cannot cope with that person, and that's led to neglect. What should the GP do if they're seeing somebody with a learning disability and they think this person is not being cared for properly at home, they're being neglected? I mean, what flags would there be that this person is perhaps being neglected or not getting the proper care, and what should the GP do if they see that?
Yeah, there would be all sorts of flags. So care not being sought, people not being brought for appointments, maybe a visit's requested out of hours often, and we might get a note back into the practice to say there were some concerns. If the person is brought in and then, as you say, they're unkempt, they're neglected, we had one person who was very thin and we thought they were not being fed properly. So any concerns about safeguarding, as with any other safeguarding concern, we have to refer to the local safeguarding team, outline our concerns, then it will be taken up by the safeguarding team locally.
Almost assuming that this person with a learning disability, the learning disability is quite minor in the sense that they do have a sufficient amount of independence. And this is a favourite TV trope. You sort of get somebody with Down syndrome and call midwife getting all upset because somebody split them up with their girlfriend. Yeah. And people with learning disabilities will want relationships just as anyone else might. Mm. How would you support somebody who would wish to engage in a sort of a sexual relationship and like talk about how them to do that safely, and maybe even talk about family planning if that was appropriate?
Yeah, so as with any other person who comes in maybe with a penile discharge or a vaginal discharge or asks for contraception, you would assess their context, their age. Have they got multiple partners or new partners? Are they at risk of sexually transmitted diseases? And with a person with learning disabilities, you're trying to assess the capacity to make decisions about sex, about safe sex, about when to seek help, about contraception, and about protecting themselves. So it's a very individual consultation, but it's about assessing capacity and being aware that if there's any element where this person might be being abused, then is there a safeguarding issue that you need to be concerned about?
Like with any patient, you would have to be very individualised care anyway, but particularly with a learning disability, because there's just sort of additional challenges with that person.
Yeah, absolutely. And again, I think it comes back to, do they have a good relationship with any of the practitioners in the practice? So, do they see a particular nurse for their diabetes check, or do they see a particular healthcare assistant when they come for their annual learning disabilities review? Do they see one of the pharmacists or one of the GPs about medication? So, who is the best person placed to have that discussion?
What are your takeaways for GPs?
Just going back to the Learning Disabilities Health Check Scheme, make sure that the processes in your practice are really well laid out, people's responsibilities are laid out, that it's not a tick box. It's, okay, let's have a first appointment with a healthcare assistant or a nurse practitioner. And then if there are any concerns related to that, or any blood tests have been done, or the person smokes and needs advice, that sort of intervention's done. And if the person's on multiple medications, they need to have a medication review either by the GP or by the pharmacist, so that it's, as I say, it's not just a tick box exercise. It actually is a holistic review of the person, and changes are made if those changes need to be made. And offer continuity of care. And this is not just about people with learning disabilities. We know that continuity of care for many patients is good. It improves outcomes. It's particularly important for people with learning disabilities so that they trust in the practice. I think we need to look at how we can improve access to care for people with learning disabilities. The online query system may not be appropriate. It certainly doesn't fit some groups of people. That when we're giving information, we give it in a simple, understandable form, possibly using infographics. Really ought to have all staff having appropriate learning disability training, and that's up to date. And then, as I've said, the health check, it should be delivered properly with good all-round care, not just as a, well, we've done that and we've ticked the box.
Thank you so much for speaking with me today, Carolyn, and thanks to our listeners for joining us. Don't forget that you can claim CPD credits for listening to these podcasts, and there are many more on the MIMS Learning website. I've been Dawn Liz Powell, speaking to Professor Carolyn Chew-Graham, and this episode was produced by Jude Owen. Look out for our next episode, where the MIMS Learning editorial team will be bringing you more highlights from the comprehensive CPD on our website.